Okay, there we go. Okay. All right, and this is where I wanted to start talking right here. So to put implementation science in sort of the context of the whole kind of public health scientific research pipeline, we think about efficacy trials, effectiveness, pragmatic and cost effectiveness trials, implementation studies, and dissemination studies. So things don't always work this way, but this is the idealized sort of research pipeline. And in efficacy trials, what happens is they're usually kind of phase 3, individually randomized clinical trials of investigational drugs and devices. And they're usually done in very relatively high budget research settings with lots of exclusion criteria and academic researchers and so forth. And they establish the biological efficacy of a particular drug or device. Should that be found efficacious, then we might move on to what's now called an effectiveness trial. Often a somewhat synonym is a pragmatic trial, and sometimes cost effectiveness is also studied at the same time. And in effectiveness trials, we might take that same drug and device, but now we're kind of interested in how well it works at the community level. So oftentimes effectiveness trials and pragmatic trials are cluster randomized, say by providers, provider practices, clinics or facilities, villages, neighborhoods, and so forth. And the exclusion criteria, it's encouraged that they be as minimal as possible to exclude as many people who might be eligible for this treatment, should it be shown to be effective and cost effective. And they tend to be larger and maybe run for a longer amount of time. And then cost may be taken into account as well. Then should a particular intervention, now I've moved from the word drug or device to intervention, because oftentimes a drug or device may be embedded within a much more complex program at the effectiveness stage, where we'd be looking at not just sort of biological impact or health impact, but also it's how well it can be delivered. In this classic pipeline, should a program or intervention be shown to be effective and cost effective, then we might move on to an implementation study. And there we might be taking the program that was the multi-level program that may have been shown to be effective and cost effective at this second level of research, and be adapting it contextually, tweaking, adapting, modifying the program for new contexts, such as from one country to another, from urban to rural, from, say, in the United States, from the north to the south, and so forth. And then also experimenting potentially with cost-effective ways of implementing it to kind of streamline the delivery. Also at the implementation phase, we'd be looking at scale up and scale out. And these things could be done with primary endpoints not even being health outcomes at this point. They might purely be things such as adoption, reach, and so forth. And then finally, in the last stage, dissemination, that's all again about the scale up stage. The scale up meaning making it more available in the particular context that was studied, but to everybody within that context and everybody like those who were in that context. And then scale out meaning to everybody, to other places. And again, there could be further adaption needed at that point. Okay, so what is implementation science? A number of definitions have been posed, and maybe the one at the bottom is the simplest and maybe one that I prefer the best. Implementation science is about determining what works in real life full-scale settings. It can also say the blue boxed definition, a systematic scientific approach to ask and answer questions about how to get what works to people who need it with greater speed, fidelity, efficiency, quality, and relevant coverage. And then the middle definition, I think, is the one that's used by the NIH in the Dissemination and Implementation Science Study section that's recently been closed down and reissued in with some greater specializations. That's been defined, implementation and prevention science there, that was defined as the scientific study of programs and interventions which promote the systematic uptake of clinical research findings. So here it's hearkening to the pipeline I was just discussing, and other evidence-based approaches into routine clinical practice and public health policy, hence improving the quality, effectiveness, reliability, safety, appropriateness, equity, efficiency of healthcare. So hopefully that gives you some sense of what we're talking about here. It's not that there's a single uniform definition that's kind of universally agreed on by everybody, but it's definitely getting at not so much showing that interventions, programs, and so forth are effective, because that's already been done in these pragmatic and effectiveness trials, but at getting them to the largest populations possible in an efficient way and making sure that quality is maintained. So very practical, but also very challenging. So another piece of this in implementation science, since we're studying evidence-based interventions, is that implementation science studies, we call it the 3 R's: rigorous, rapid, and relevant. So rigorous has to do with, even though we're studying very practical things, like implementation science in some ways is, the outgrowth of what had been previously called program evaluation, that we still want to use state-of-the-art methods. The studies use, formal power calculations for cluster randomized designs. They can take into account multiple outcomes, and the methodologies can use causal inference methods and all sorts of multi-level analysis methods and so forth. There's no drop-off in the rigor in implementation science necessarily. And in fact, it's very challenging to be rigorous in these kinds of settings where the data are imperfect. So when we get on to rapid, we also need to get these answers very quickly, because we're talking about urgent public health questions. And we want to have our implementation science work be informative to policy development and formulation and promulgation, not coming afterwards. So in order to be rapid, we want to make use of existing data, electronic health records, other sorts of records, and move things along quite rapidly, even though we're trying to maintain the rigor, just as we would in a phase 3 randomized clinical trial in an academic setting. And then relevant, we want to be answering the most important public health questions of the day. And those would be decided by public health leaders, policy directors, and Ministry of Health officials at the different country, district, and even community levels, as well as the community itself. So it's different than in the case of, say, academia, where somebody is a research oncologist and they're working on breast cancer and trying to figure out some new treatments to cure and prolong the life and quality of life of people with breast cancer. Implementation scientists wouldn't necessarily be choosing the topical area of interest. They would let the public health community make those choices. And then where we might come in is, okay, this is an important policy question. How are we going to study this and get you some answers rigorously and rapidly? So given all of what I've said, it might be evident that implementation science is somewhat different from epidemiology, clinical research, and so forth. And at the study design level, we have these sorts of considerations. So the first one is that implementation science is guided by implementation science theory, models, and frameworks. What I mean by that there are social science theories of behavioral change, such as C4, CFR, the Consolidated Framework for Implementation Research, or REAIM. There's a number of them, and they guide the work in the sense that they help determine where we are in the pipeline of identifying barriers to full uptake at high quality of a particular intervention, and what has been facilitating this so far in this particular context, and then figuring out how to expand it, how to adapt it in a new setting, and so forth. And many of these things involve behavioral change and other sorts of human factors that are not typically the objects of study of clinical researchers, epidemiologists, and biostatisticians. So implementation science brings in some new team members, namely social scientists, who might be psychologists, social workers, um, medical anthropologists, and then also economists, because we still tend to be looking at cost from the sustainability point of view. So I think I've already mentioned that implementation science tends to intrinsically be multi-level, because in terms of developing and sustaining successful interventions to address important public health programs, we need to engage often the healthcare system, policymakers, organizational leaders, healthcare providers, clients, and their families and social networks. And social networks, I'd like to just say a word about. It's a little throw in here, but actually it's an area of research for my group and maybe other people who are participating in this discussion, that on the provider and client level, at least, it's quite possible, and it's starting to become increasingly documented, that interventions that not everybody, not all providers and not all clients necessarily need to receive an intervention in order for an intervention to spread throughout a health system or throughout a community, because people have social relationships and can influence one another in terms of the adoption of new practices at the provider level, or the uptake of new interventions at the client and family, neighborhood, workforce, and so forth levels. So we're interested in leveraging these networks to perhaps make certain types of public health interventions be more cost effective and have wider reach and sustainability. Another piece is that implementation science studies tend to be dynamic, in that many of you, if you've worked in HIV, it's very well known, say the HIV treatment cascade, the TB treatment cascade, and so forth. And then to say prevent, say HIV, or to ensure the highest quality of life of people who are HIV positive, there are all these different steps along the way that involve different types of treatments, interventions, actors at different levels. And one of the things we do in implementation science is we might map those cascades and figure out where the weak points are, and then figure out what interventions can we bring in to strengthen the success of the entire cascade by targeting its weakest points. So the timing of delivery of intervention components can be along the cascade, can be as important as the delivery itself. And then, as I mentioned, just as in effectiveness trials, I can't say for sure there would never be an implementation study that wasn't individually randomized, but in general, the implication for design of these sorts of studies is that there tend to be group level assignments to study intervention components, and they could be at the district, hospital, facility, practice, provider, or community levels. And even clients themselves can be group level if you think that every client is a member of a social network, and that by including them, we're actually indirectly including their entire social network as well. Okay. I'm now trying to go on to the next slide. It's not behaving. Let me try again. Oh, there we go. So, so there's many study design options in implementation science, and they depend on a wide range of factors. The factors are listed here: what the research question is, the type of clinical or public health intervention, the type of implementation strategy, feasibility, cost and personnel, the setting, who are the stakeholders, what are the logistics, the target population, timeline. Ethical issues come up, and they in fact can be very different than those that we're used to in randomized clinical trials of investigated drugs and devices. And that's an area of active development that I'm quite interested in. And there might be other people here who are interested in being involved in this as well. And then funding opportunities. So there we go. Okay, so sorry. Get this. Okay, there we go. So we have a number of study design options in implementation science, and the rest of this talk is actually going to be focusing on this aspect of what in the first part, I kind of set the stage by kind of talking about some of the key issues in implementation science, and then that, of course, informs what the study design options are. And EK, I'm not monitoring the chat, and I do welcome questions and comments. So if any are coming up, EK, it would be great if you could throw them in, because I'm not seeing them at the same time I'm seeing my slides. So we talked about experimental study design. So those are usually, are there any questions or comments so far?
That you go on, we ask the questions at the end of the lecture. Let everybody write down the questions, or when we open for question and answer, they can ask. Thank you.
Okay, sure, that's great. We can do it that way as well. So experimental, that's kind of also synonym for a randomized design. So randomization, as many of you probably know, is considered the highest form of the highest type, the strongest form of study design. It allows causal inference in the simplest ways, with the simplest types of designs. And when we randomize by randomly assigning the intervention to one group versus another, we on average control for all sorts of confounding, ensuring balance between the two groups, that imbalances might not lead to, on average and under the null, would not lead to incorrect inferences, and on average will give us valid estimates. It will control for various sorts of selection bias, and we don't have any measurement error, because we know who we gave, who or what groups we gave the intervention to or not. So like we have several types of these experimental designs, some of which most people on this in this symposium would be familiar with: RCT, randomized clinical trials, which are individually randomized. And then we use the acronym CRT, or cluster randomized trial. There are also group randomized trials, very common in implementation science. And then there's another type of cluster randomized trial that's become increasingly popular, the step wedge design. And I'm going to be talking in some detail about that. And our group has here at Yale, at the Center for Methods in Implementation and Prevention Science, we've done quite a bit of work on extending study design, CRTs, and step wedge designs. There's a very useful design called the MOST design that is becoming increasingly popular in implementation science, that I'll talk about. And then there's the LAGO design, or Learn As You Go design, which has been developed by our group, that I'll also talk about briefly. And then in the interest of, yes? Okay.
He's gone.
Okay, sure. In the interest of rapid in implementation science, there are also quasi-experimental designs. So these designs take advantage of certain features of the data in order to get sort of under certain circumstances that are very well defined and may or may not be valid, but often are, we can get inference that's almost as strong as that in the randomized designs without having to randomize. And randomization is an expensive and slow process, and often may not be, I'm starting to increasingly think myself, the very best way to get the answers that we need in public health rigorously and rapidly. So in the group of quasi-experimental designs, we have pre-post designs, difference in difference designs, interrupted time series designs, and controlled interrupted time series designs. And I'll talk a little bit about those as well. And then finally, there's observational research, which in my view has been underappreciated and underutilized in implementation science because there's such a big emphasis on, I think, probably the rigor and wanting to be able to make causal inference without having to make a lot of assumptions. So there's been a strong emphasis on experimental designs, so far, very much less use of observational designs, such as the classic cohort, cross-sectional, and case control studies that can be embedded in the ongoing practice of implementing public health programs and simultaneously evaluating them using observational data methods, in particular causal inference methods. And then finally, there are some other designs that you may have heard about that have come up in implementation science, hybrid designs and mixed methods designs, which I'll also mention as we go along. So quite a lot of options, actually, as we can see. So, okay. All right, there we go. So here, this slide refers to these two citations that I have down here at the bottom, and it's called the Precise Pragmatic Explanatory Continuum Indicator Summary. And it's a way of evaluating how pragmatic your trial is. And in some cases, in the United States, we have this pretty important funding mechanism called PCORI, and they explicitly fund pragmatic trials. And if your trial isn't pragmatic enough, it won't, it's very unlikely to be accepted for a PCORI funding mechanism. And what the PCORI, this pragmatic trial, there are these various criteria. I've mentioned some of them already. So eligibility, and these all are on Likert scale. So the idea is, again, the fewer eligibility requirements, the better. Recruitment, the more general and open the recruitment is, the better. The setting, the more community-based, population-based the setting, the better. The organization, and so forth. So all of these things are used to evaluate how pragmatic a trial is. And it's worth doing it if you're designing a study and you're really wanting it to be in the effectiveness, implementation part of the continuum. You can get access to these papers and literally rank your design and experiment with different possible designs and try to get your study to be more and more pragmatic. And I highly recommend it because that's what we need in public health. We need pragmatic trials that will really tell us how well our interventions will work at broad scale in the full population and the community. So, and experimental designs can be pragmatic. That's why I showed the pragmatic slide first. Even a randomized controlled trial, an RCT, can be rated on the Precise scale and be made more pragmatic. And then, as I mentioned, cluster randomized trials, and then step wedge designs. And here's a paper that was published in the Annual Review of Public Health if you wanted to read a little bit more of an overview of the study design options for dissemination and implementation science. So now I'm going to talk about cluster randomized trials, and I'm going to give an example of a trial that I worked on myself. I went a little too far. I think I did again. Sorry. No. Okay, there we go. So cluster randomized trials, this is like a graphic. It gives a graphical view of the difference between cluster randomized and individually randomized trials. So over here on the left-hand side, we have a individually randomized trial, and on the right-hand side, we have a cluster randomized trial. You can see that they can have the same amount of people. So each one of these smiley faces is a participant in the study. But in a cluster randomized trial, we randomized by groups. So there were 4 groups here, and then 2 of them became part of the intervention group, and then 2 of the groups became part of the control group. And then, of course, every group member within each of those groups became part of the intervention group, and so forth for the control group. And so that's the idea. And then when that is done, and oftentimes it has to be done because the intervention is actually applied at the group level. And even when it doesn't have to be done, pragmatically, and in terms of rapidity, for example, it might make sense to have a study design that's cluster randomized anyway. That's the way we would go. And that's usually what I see. And the study design calculations and so forth are all, and the analysis are somewhat different when we have this. So now I'm going to go over a case study that I was involved with when I was at the Harvard School of Public Health, that was in collaboration with Management Development for Health in Dar es Salaam, Tanzania, an NGO that's the PEPFAR implementing partner in the greater Dar es Salaam region. And together we conducted the study called Familia Salama, and it was a 2x2 cluster randomized trial. So 2x2 factorial means it's another design feature that can be used in any one of these types of studies, but where it's a very old idea, but it allows us to study multiple interventions or implementation strategies, components at the same time in one single study. And there's no kind of statistical limit. You don't lose power. You could do a 2x2x2 or a 2x2x2x2 and so forth. The main limitation to how many things we can study at one time using this factorial approach is actually just logistics and feasibility. It gets very complicated and confusing when you're trying to run a study at scale at a population level, and like every group, like this one is doing this, this, and this, and then the next one is doing some other combination. It can start to become unmanageable. But I also would like to bring it up and encourage people, like at least if you are conducting a study and you're going and you have, like, say, if you have a well-funded study, a population-based effectiveness or implementation trial, for very little, for no increased sample size, you can basically add another factor and study 2 things. And it's like, why not? So just throwing that out because it's underutilized as a design approach. But here we did this where we compared, we were looking at an enhanced community health worker versus standard of care to produce, to increase uptake of the World Health Organization's recommendation that all pregnant women should have at least 4 A&C visits. And then that was crossed with option A versus option B, which are 2 approaches to prevention of mother to child transmission of HIV. Now, option B has been universally adopted among HIV positive mothers. So we had these 2 things crossed in this trial. And here is the name of the paper that's actually recently been submitted, just publishing on one of the 2 factors, the impact of community health worker intervention on uptake of antenatal care, cluster randomized pragmatic trial. And see, very, very large trial, almost 250,000 women in Dar es Salaam, Tanzania, who reported to ANC at least once and were found to be pregnant. And you can see that these kinds of big population-based effectiveness success and implementation trials are often highly collaborative, and they involve a big team. If we're working together in an international partnership, you can see that there are people, from different, both from, say, the host country, as well as, say, the technical support partners and so forth. In our case, we had people involved from Norway, Germany, the United States, and Tanzania involved in this trial. And here's all the different institutions that we all came from. And so here's a schematic of the design. And so this sort of an intervention was implemented and rolled out at the ward level. So in Dar es Salaam, there were at that time, there were 3 districts for the whole greater Dar es Salaam region. And we included 2 of the 3 districts. And as many of you may know, Dar es Salaam is one of the largest cities in sub-Saharan Africa. And within those 2 districts, there were 60 political wards, and we randomized them to one of, you could say, 4 arms, where first the 60 wards were randomly assigned to either the community health worker intervention or not, and 36 were assigned to the community health ward intervention, 24 to standard of care, and then of those 36, 22 went to option B, 14 to option A, and then and so forth. So you can see how that's divided up. And then you might be wondering, well, it's kind of imbalanced by ward. And why was that? This is a tricky aspect of balanced design in a cluster randomized trial, because the wards did not have the same populations and the same expected populations of pregnant women who would be delivering during the study period. So we were trading off both kind of having a sufficient number of wards with having a sufficient number of women within the wards. And so you can see that what ended up happening was we expected to have around, in the first intervention, we expected to have a certain number of pregnant women in option A versus option B. And what we observed was quite different. And then similarly for the community health worker intervention, we did our best to try to balance the number of pregnant women who would be in the community health worker intervention versus standard of care. And then what happened was we saw something very different. And we saw, and then in addition, you might notice something else, which some of you who have actually run studies may have also seen, that it can be quite challenging to specify what some of these input parameters are before a study is conducted. So one thing that happened was, you can see that what we expected, and then what we observed was, quite a few more pregnancies during the study period that than were expected. We underestimated the fertility rate in this area based on the population level data we had. And then you'll also see a little later on, we also overestimated the HIV transmission rate. Or actually what we really overestimated was the proportion of pregnant women who are going to be HIV positive. So as many of you know, all of the various programs that have been implemented to kind of end the AIDS epidemic have been quite successful. We're not completely there, but there were huge improvements that were made. And even during this study period, from the time we designed the study to the time the study was actually conducted, the HIV positivity rate went down substantially. I think we predicted that it would be around 12%, based on data existing at the time when we designed the study and submitted it for funding. And when we actually ran the study, I think it had dropped to 6%. So when those kinds of things happen, they can really detract from the power of your study unless other types of adaptive study designs are brought to bear. But luckily in our case, because we hadn't planned in an adaptive study design, we also had a higher pregnancy rate. So we compensated for the lower HIV rate, which of course is a wonderful thing, with a higher pregnancy rate. So we ended up maybe with around the power that we might have hoped to have had at the start, with these input parameters being quite different than what happened in the reality. So the results here, their intervention significantly increased the likelihood of attending 4 or more ANC visits by around 42%. And the intervention also had a modest beneficial effect on the total number of ANC visits. It increased them by 8%. It wasn't successful in improving the timing of the first visit, because another kind of secondary goal was to hope that women might become aware of their pregnancies earlier on and get an initial ANC visit even in their first trimester. And so what we concluded was that trained community health workers can increase attendance of ANC visits in Dar es Salaam in similar settings. However, additional interventions would be necessary to promote early initiation of ANC. And then the study also demonstrates that routine health systems data can be leveraged for outcome assessment in trials and program evaluation. I neglected to mention that among these 250,000 pregnancies in these 60 wards, at that time, there really wasn't electronic health records in the facilities. So what was there were logbooks where intake healthcare providers would be entering certain data elements at the different types of clinics that women were going to. And what we did was, at the end of the day, we had study staff coming in, and we had like a database set up that looked just like the logbook. And they would come in and they'd enter all the data from the logbook for that day. And we did that for all of those pregnancies. Now, ideally, as more and more healthcare systems around the world become reliant on electronic health records, that wouldn't even be necessary. And a study like this, at full scale, 250,000 pregnancies over a period of around 2 years, could be conducted rapidly and rigorously with no additional research data collection, which is kind of the goal. So that's an example of a cluster randomized trial. That's sort of an effectiveness implementation trial. And then maybe I could say something about that, that the endpoint of, say, women having, say, 4 or more ANC visits during their pregnancies, that has nothing to, there's no health outcome there. It's a pure implementation outcome, where there's an evidence-based intervention. The WHO has reviewed the data very carefully. They've made this recommendation, and presumably the idea would be, by having 4 or more ANC visits, and of course receiving quality care at those visits, that we would be able to increasingly bring down the maternal mortality rate, which has also happened all around the world, as well as the sort of under 5 perinatal and neonatal mortality rates. But we weren't even measuring those as primary outcomes in the study. That's already been established through effectiveness and efficacy trials. So the implementation science were all about studying, can we successfully implement a proven intervention, and in this case at scale. That's the purpose of the study. So that's actually, it's, when I first started doing this, having a biostatistics and epidemiology background, it's kind of shocking to think that you could propose a big study like this and not even have a health outcome, just be studying an implementation outcome. But you come to realize that's really what we need for the most part. And if it's possible to also look at the health outcome without slowing down the trial, increasing the expenses greatly, it's a great thing to do. And later on, I'll talk about hybrid designs. But now we're going to talk about stepped wedge cluster randomized control trials. So stepped wedge designs are popular for a number of reasons. So let me just explain what this schematic diagram means. So what happens in this particular case is The rows are clusters. So we have, or they could be groups of clusters actually. And here there are 5 groups of clusters. The columns are time points. So what happens, let's just look at this first row. So this row, this group, 1, so there could be 1 village, say, that's in this group, or there could be 5 villages in this group. But they were randomly assigned to pattern 1. And what that means is that those villages assigned to pattern 1, we take baseline data for everybody. But then at time 2, which could be in 6 months, a year, 2 years, it's often, in my experience, something like 4 months, 6 months, all the clusters randomly assigned to pattern 1 transition to the intervention. And then for the next 1, 2, 3, 5 periods, they're in the intervention group. Then those clusters assigned to pattern 2, they stay on control for 2 time periods. And then it's at time step 3, they go on to the intervention group and so forth. And so what you notice is we have baseline data on everybody and everybody. And then at the end of the study, we also have every cluster and every individual within those clusters are assigned to the intervention. So 2 things happen. One is that oftentimes in implementation science, we're studying evidence-based interventions. So you could say, how could we withhold having well-trained community health workers from anybody? Well, that's not necessarily an optimal thing to do, but a sort of compromise is that by the end of this study, all women living in all of the wards, if it had been a step wedge design, which it wasn't, would have access to this enhanced community health worker intervention. All the facilities would be trained to this new evidence-based intervention. So it addresses some of the ethical issues that might come up in implementation science when we're studying evidence-based interventions. What's in equipoise is not whether the intervention works or not. What's in equipoise is whether this implementation of the evidence-based intervention will work. So it's a little bit of a subtle difference from an ethical point of view. And it's also why people are discussing and writing about new ethics for public health. And then the other thing that I want to point out about step wedge designs that make them very rigorous from a causal inference point of view is that at each time point, which clusters and then which individuals within the clusters are in the intervention group or not is completely randomly assigned. So when you contrast time 2, these 4 to this one, it's a random contrast. And then time 3, these 3 to these 2 is a random contrast and so forth. So between clusters at any given time point, we have this fully randomized design. And then what we also have is this element of pre-post, because say, we could, even with just this first row, we could estimate and test the effect of the intervention because we have at time 1, all of the villages or clusters assigned to time 1 are not in the intervention group. And then we have 5 periods where they were, and the before after can be compared. And so what we worry about with the before-after design and why it's called quasi-experimental rather than experimental is because there's one other thing that's changing. If it's the same villages, clusters, and people, or comparable people in this one row of all the clusters assigned to this row at this one time, they should be the same with respect to all time invariant confounders. But time is happening here. So there could be no intervention effect, but let's say between time 1 and time 2, something else happened in the background, like the government instituted a new program, or some new drug became widely available, or there was a natural disaster. So then comparing the before after within the same clusters will be biased by these time varying effects. And so without these contemporaneous clusters happening at the same time, we can't control for those effects. So it's almost like an enhanced pre-post design where we're controlling for time varying effects through randomized contrasts. So it's a very strong design. And here's a good paper to read if you want to learn about it a little bit more. Now I'm going to give an example of a study I worked on that was a step wedge design. It was called early access, or it studied early access to ART in what's now called Eswatini, Swaziland. Its primary funder was the Clinton Health Access Initiative. Other funding sources were brought in, the Dutch lottery and some other sources. And what we were looking at here was the impact of early initiation of ART versus national standard of care of antiretroviral therapy in Swaziland's public health sector system. And it's called the MaxArt study. So what made this study a little bit different than the studies of the other big trials of early initiation or early access to ART that were happening around the same time was that we were looking at the impact not of controlling community HIV incidence, but we were actually looking at the impact of early access to ART on the clients themselves, the HIV positive participants who would, under standard of care, not be initiated to ART until later on in the development of their disease, when they started to develop different types of symptoms, which I know many people on this call would be familiar to when CD4s dropped below 250, and then it was changed to 500 and so forth, or certain symptoms and AIDS-defining conditions developed. That was the standard for many, many years until early access to ART happened. And it really wasn't known what the impact would be of early access on HIV positive people themselves, both in terms of their health outcomes as well as even more implementation type outcomes, such as retention in care and this issue of, say, developing resistance if people are being initiated very early on when they're not showing any signs of illness and so forth. So again, because I think partially both for logistical reasons, which is another reason why we like step wedge designs, it was Swaziland or Eswatini didn't have early access to ART when the study started. And so to train the providers to do this, to get the medications in at the scale and volume that was needed, to have the testing facilities scaled up and so forth, it wasn't possible to do that all on and be ready on August 14th when the study started here. So by phasing it in, it made it possible. We randomly, in this case, there were 14 facilities included, so 2 in each one of these clusters, and we were randomly rolled them in to early access, giving us time to properly set up each pair of facilities to be able to implement early access in a high quality manner. And then, of course, at the end, all the facilities were in early access. And in fact, what I didn't mention, I mentioned this early on about, like, this was a high grade, research quality study. There were extra resources put in and so forth. And somewhere in the middle of this, WHO decided everybody should have early access, and Eswatini immediately adopted that recommendation. And that was the end of the standard of care we were studying. So our power was compromised, not fully, luckily, but that's this issue that I'm mentioning, that rapid is just such an important aspect in implementation science. And I think it's an area of, sort of research. We need good examples as well as possibly new methodologies of moving these studies along so that the policy, when policies are being made, the policymakers would actually have data from studies like this to inform their decision-making, which wasn't the case here. So here is a published paper on the protocol if you wanted to learn a little bit more about the design of this study. And then the results. So this study was conducted between 2014 and 2017. 3,405 participants were enrolled. The 12-month HIV care retention rates were 80% and 86%. So there was an improvement. 6% retention means alive and remaining in care. So it's a comprehensive outcome that both includes sort of the implementation aspect of not losing people for coming in, getting their medications, being checked to make sure their disease isn't advancing, and then also their health outcome, making sure they're still alive. So again, 80 to 86%. It's not huge, but it's still, a nice improvement. And then the 12-month combined retention and viral suppression endpoint rates were 44% versus 80%. So that's very, very big. And, as we all know, getting people on ART really improves viral suppression rates. So that was shown to be very beneficial and highly significant. So we've considered this to be good news in terms of early access to ART also being strongly beneficial to the clients themselves, not just society as a whole. And at the same time, we noticed that there were significant gaps in the healthcare system's ability to provide viral load monitoring, with 80% participants in standard of care and 60% in early access, each having a missing viral load. So that's an example of a stepped wedge cluster randomized design that both was looking at kind of a combined implementation health outcome as its primary outcome. Okay, I think I'm gonna, all right, so a little bit about, I wonder, I'm sorry. I just thought maybe I can get rid of this. Oh, okay, now I got rid of all these drawings. Sorry, there were all these colored pencil things on here. Step wedge designs, when are they useful? When there's evidence to support of the intervention or resistance to a parallel design where only half received the treatment. Another aspect of step wedge designs, it's often believed, and this is on the ethical side, that the treatment is service delivery or policy change, and that it's often believed that when what's being studied is a service delivery issue or policy change, we don't need individual informed consent. And then when the intra-cluster correlation is high or the cluster size is high. So I haven't talked about the intra-cluster correlation, but that's a very important input parameter when we look at cluster randomized designs. And what that measures, we usually call it the ICC, or sometimes you'll see it indicated by the Greek letter rho, is that it tells us how highly correlated the outcome is, particularly the primary outcome, within the clusters compared to between the clusters. So let's say if we were, let's say in the IAMRAT study in Eswatini, if certain facilities, let's say, had very high mortality rates, and then other facilities, at baseline had low mortality rates, that would suggest a high ICC. And when you have a high ICC, a lot of variability in the event rate between clusters, you lose power. In a standard cluster randomized trial, you lose a lot of power. It's dramatic. In fact, the ICC, like any other correlation coefficient, ranges from 0 to 1. And when it's 1, that means that the only variation is between facilities. There's no variation between individuals within a facility. Then your effective sample size is essentially the number of facilities, say 14 in IAMRAT, compared to, say, 3,205, which would be the effective sample size if there was no variation in the event rates between facilities, and all the variation was just between clients. So when the ICC is high, you're going to need a lot of clusters to get power in a cluster randomized trial. Whereas in a step wedge design, because of the feature that I showed you, that step wedge designs completely exploit the within facility contrast, the pre-post contrast within facilities, you lose very little power when you have a high ICC. So it's a feasible way of running a cluster randomized trial when there's a lot of heterogeneity between the groups. And then, of course, because of that, it can be more efficient over the parallel design. I'm going to skip this point about why there might be caution, but one caution is this piece about clusters not being able to follow the randomization schedule. So, we can say, okay, you start at time 2 and you start at time 3 and so forth. But, we're talking about pragmatic trials embedded often within public health systems. And there's other things that come up. Maybe some issues have come up. Some people have left. It's just not possible to start at time 2. They have to start at time 3, that sort of thing. And then once the random patterns start to be violated, then you no longer have the strength of the causal inference from the randomization, and it becomes more like an observational study where the facilities just chose when they were going to start the intervention. Okay, so how are we doing on time, Ike?
Thank you, Donna. Please continue. We would like to just have what you have prepared for us. I'm sure we still,
okay.
just go on, please, go on. I'm sure
Okay.
we will be okay. We're happy to have you. We're enjoying it.
Because I tend to underestimate how quickly I can get through a talk, and I like to enrich it with things that aren't necessarily on the slides, and then it goes a lot more slowly. But just let me know if you feel like I need to wrap up. Otherwise, I'll just keep talking about everything I've prepared to discuss today. So now we're going to move from experimental studies to quasi-experimental and non-experimental studies. Next thing. Okay, so observational study designs. So for those of you who have studied biostatistics and epidemiology, we know about these very well. We're studying and assessing phenomena as they occur naturally. We can look at policy initiatives. It's hard to think about randomizing a policy initiative. We're not manipulating. Cohort studies can be conducted within electronic health records, as well as cross-sectional studies. And of course, we don't necessarily need electronic health records, but they sure do make it easy to do very quick evaluations of interventions and implementation strategies as they're occurring in the health system in a completely pragmatic manner. And then here's a bunch of papers in the implementation science literature about the use of observational studies. And then there's quasi-experimental study designs. I listed those out earlier, the before-after design. So when we, I just wanted to see what I'm going to do next here. Oh yeah, okay. The before-after design, that would be, as I illustrated with the step wedge design, if we just had one of these rows, we could just compare a facility or group of facilities, what their outcome rates were at baseline, compared to what their outcome rates were after a certain lag, after the intervention was delivered. And because we're completely we're comparing clusters to themselves, we're controlling for all known and measured risk factors, which could be potential confounders, um, that are not time invariant through this pre-post design. That's why it's called quasi-experimental, because there's full control of confounding for time invariant characteristics in a pre-post design. And, the individual level analog of a pre-post design would be an individual, matched pairs study where we use, say, the paired t-test to evaluate the results and assess the impact of an individually applied intervention. And then there are cluster analogs to the paired t-test when we conduct a pre-post or before-after design in a clustered setting. And then the controlled before-after design, which you might have also heard as the difference in difference design, is a pre-post design enhanced by having other clusters or groups for which there's no intervention is applied. And so by subtracting the change in the groups where no intervention was applied from the change in the groups where the intervention was applied, we can subtract out all the time invariant characteristics as well as the time varying characteristics. So that's a very nice design. And again, doesn't require randomization. Then there's interrupted time series designs, where we look at multiple assessments prior to and following introduction of an intervention. And we might be able to more accurately assess the outcomes or behaviors than in a single pre-post design. And it's kind of like a interrupted time series design where time actually becomes a continuous variable. Instead of before, after, we've got the whole time sequence. And I'm going to illustrate that shortly. And then finally, there's another quasi-experimental design that's been used, again, to evaluate public health interventions and implementation strategies without having to randomize the regression discontinuity design, where individuals and groups can be considered to assign to intervention or control based on some a priori score or metric that's kind of independent of their outcomes. And then it's sort of in a causal inference perspective, can be treated as an instrumental variable, and causal inference can be made. And for those of you who are health economists on this call or have exposure to this, these quasi-experimental designs have been put forward. I think putting them forward has been led by health economists as opposed to, say, biostatisticians and clinical researchers. And so it's a way that I think step wedge designs and cluster randomized trials kind of gain traction, and many of the methodologies were worked out in the health sciences. And then quasi-experimental study designs, a lot of the literature arose in health economics and now has kind of crossed over into clinical research and biostatistics and so forth. And then here's an article that I can recommend that would talk about these quasi-experimental designs, sort of from a, in a way that's very accessible, I think, to a large audience. So the interrupted time series design is a way that you can look at it is through the schematic graphic. So it's considered one of the strongest quasi-experimental designs, and it's increasingly advocated for use in the evaluation of health system quality improvement interventions. When randomization isn't possible, it can also be used to evaluate other, like, population level changes in health policies. So here, what we do is we observe an outcome rate. It could be, say, HIV incidence rates. It could be, say, suicide rates, any sort of health outcome or even an implementation outcome, maternal mortality, under 5 mortality, any sort of health outcome, ideally, usually that's measured at kind of more of a population level, or even measured, and it doesn't have to be measured by everybody, like, say, using DSS survey data. It can be monitored through sampling techniques before the intervention. And so we might expect in this idealized situation, we're seeing that before the intervention, this outcome rate is stable. It's not getting worse, it's not getting better. But you could also have, it doesn't have to be a flat kind of slope. It could be getting worse or better. It could go in either direction. And then the idea is that if the intervention didn't happen, it would just trot along at the same rate that it had prior to the intervention. And then when the intervention happens, we might think that the rate drops. Let's say if this was an adverse health effect, this would be around the time of the intervention, and people can also hypothesize lag. So maybe it wouldn't be immediate, maybe it would be 6 months later or a year later. You'd see a drop in the rate if this was something to improve health. And then you also might see, in addition to the drop, we might see a change in the slope so that it might continue to improve slowly over time. So there could be a trend change. It could also happen that there's no drop, but that we just see the trend change. Or there could be a drop and then no further trend change. And an interrupted time series design at the analysis stage would allow any of these possibilities. And then with a controlled interrupted time series design, we would have other groups that we might be observing before the intervention. They could be at the same level or a different level, because what we really care about is around the time that the intervention happened, we would hope to not, if we see any change in them of a drop in the level or a change in the slope, that we'd subtract that out and not attribute that in the group that had the intervention. We could attribute that to a part of the drop and that part of the change in slope to these background time effects. And so that's why we like the control group. And here's an article about, if you wanted to learn more about interrupted time series in public health. So a few examples. So here, this was a project that I worked on in Mexico, and we were thinking about a learning healthcare system in Mexico for evaluating the performance of. In Mexico, there's something like, I think, 34 states. Just like the United States, we have 50 states, so they have 34. And these are the acronyms for each of the states. And then what we use the electronic medical records. They were trying to use them for chronic disease prevention, screening, and care. So here there was almost 2 million patients included who had had at least one clinic visit that included a chronic disease diagnosis. Chronic disease was defined here as hypertension, diabetes, dyslipidemia, or obesity among over 12,000 healthcare facilities. And then there was an implementation outcome developed that was indexed the quality of care being used for the prevention, screening, and treatment of diabetes. That was called ICAD. And then that was able, through the health records, we were able to score each facility at every month during the study period as to how well they were doing between June 2016 and July 2018 on their quality of care for the prevention, screening, and treatment of diabetes. And so what we see here is, and I apologize because this work was done in Mexico, so the graph is in Spanish, but I think what you can see graphically is what is the point estimate, which is the black vertical lines is the mean quality of care ICAD index for the state, and then the 95% confidence intervals for how it varied over the study period. And so here actually, what happened was that there were only two states that actually ended up doing worse. And then there were two states that significantly worse, because the 95% confidence intervals aren't touching the null value, which means no change. And then there were three additional states that did worse, but not significantly so. And then you can see this, these are sorted by how well they did on this ICAD score. And you can see that there was a huge variation in Mexico among these 34 states. So then, in addition to seeing like who needs help, we can also see that, there's big, oftentimes in the United States, we talk a lot about disparities, but in many other countries, there are big disparities as well. And here's, sort of a graphical illustration of how big a disparity might be between some of the wealthier, more urban, higher SES states and some of the poorer rural states. So this is a starting point in terms of documenting what are the issues, and then we might want to go in and figure out the next steps, which we would have liked to have gotten to would be, let's take the top 5 highest performing states, understand what's working there at the facility and client and system level that they're able to achieve these very high ICAD scores. And then what are the barriers to those sorts of implementation strategies that are happening in some of these states where there's either no improvement or things have actually gotten worse. And then how can we adapt these implementation strategies to create a new intervention that might improve treat chronic disease prevention, screening, and care in some of these states for which these disparities exist. And then another example here of a paper that I, along with others, recently published that gives an example of a controlled interrupted time series is looking at the causal impact of the Affordable Care Act on colorectal cancer incidence and mortality. So colorectal cancer incidence and mortality are one of the biggest causes of cancer cases and deaths in the United States. And with the changing nutrition epidemiologic transition, I think colorectal cancer is understudied around the world, but it only stands to reason, just as we've seen the increase in rates of other chronic diseases such as diabetes and heart disease, breast cancer, and so forth. We'll be seeing soon increases in the incidence and mortality of colorectal cancer. And it's known we have a efficacious evidence-based intervention for colorectal cancer. It's called colonoscopy, and it involves an examination of the colon for polyps and the removal of polyps before they have an opportunity to develop into precancerous and cancerous lesions. And it's been found to be at least 50% efficacious in randomized trials. It's also expensive. In the United States, it costs at least $3,000 per colonoscopy screening. So many Americans were not able to afford colonoscopy screening. And when President Obama brought in the Affordable Care Act, it's also called Obamacare, one of the main tenets that it brought in, which people in the public health community really liked, is that it guaranteed funding for evidence-based preventive interventions, and colonoscopy was among those and maybe among the most important. So here's a perfect example where we can study the impact of the Affordable Care Act on colorectal cancer incidence and mortality. Well, we know from these trials that if people manage to get colonoscopies, their rates, on the population level will go down by around 50% or more, but by just simply changing the law, if you think of the cascade, there's so many steps that have to happen before people might actually get these colonoscopies and get them on the recommended schedule, and then see the impact on reduction in colorectal cancer and incidence. So what we did was we were able to, we have a very big health system in the western part of the United States called the Kaiser Permanente system, and then they're divided into kind of subgroups. So I had colleagues at Kaiser Permanente in Northern California. It's an integrated healthcare delivery system. It's a private system with over 4 million members who are representative of the regional population. And so we used an open cohort cohort of Kaiser Permanente of Northern California members who were 50 years or older between January 1st, 2000 and December 31st, 2017. So there were over 1 million such individuals who were part of the study population at some points in time over this period, and with around 220 million person months of follow-up. And during that time, there were almost 20,000 colorectal cancer cases occurred, and over 2,600 people died of colorectal cancer. So that's basically the study population here. And then here is our interrupted time series design. So it wasn't a controlled time series design, but what we saw is, so this is colorectal cancer incidence, and on the y-axis, so it's how many cases per 100,000 were occurring in the study population. And then here's the red line, that's when the ACA, the Affordable Care Act, was rolled into public policy. And then here's the after data. And what we're seeing, and then these, the very, very jagged lines are the natural variation in the monthly rates, which is the kind of thing we see. Statistical random variation. We don't see smooth curves when we look at rates on a very fine scale like this. They're kind of going up and down. And then the red line kind of smooths these curves without testing any particular hypothesis. But we see that, you know, the rate before the Affordable Care Act came in, it was kind of fluctuating up and down a little bit. It's not that when I showed you that earlier slide of the sort of schematic of an interrupted time series design, there was just a straight line going through here. It's not quite that. This is real life data, but that we do see after the AC came in, even just, you know, not imposing any structure on the model, that we see that the colorectal cancer incidence went down fairly quickly. Now you might wonder why. Well, they take out these polyps that are precancerous, and you don't get cancer. So it can happen very quickly. And then what we did was then we fit that classic interrupted time series model to the data. And so what we saw, that's this line here, where you can see that what was happening was colorectal cancer actually in the background is slowly going up a little bit. In this part of the country and probably everywhere in the United States. But then ACA came in, we actually, I mean, we couldn't believe it. You know, there was this, we saw this drop, and then just like in the classic design, and this was significant. And then we saw this continued slower decrease in trend. So right, it was at this point that everyone in Kaiser Permanente was able to get access to colonoscopies. And so it lowered the rates right away, and then the rates continue to decline. So that's an example of an interrupted time series design to study the implementation of an evidence-based intervention at the policy level, namely through the Affordable Care Act. And here is the here are the co-authors, and then here's the publication. So now I'm going to talk a little bit more about some more innovative designs, because really everything I've talked about so far, the step wedge design, cluster randomized trial, interrupted time series, and so forth, those have been around for quite some time. But now we can go into a little bit more of some some novel designs that are just starting to be considered in implementation science. In particular, MOST, SMART, and LAGO. So the MOST design is one design that's very well suited for complex, multi-level, multi-component interventions. That can be a very hard thing to set up at the start of a study, where when you've got all these different features at different levels to know exactly how to constitute your intervention package, both what's in it and what's not in it, and at what kind of dose or strength of implementation should each one of these components be. So in the MOST design, which was developed and promoted by a researcher named Linda Collins, and here's two of the key citations to this design down here, there are 3 phases. So the first one is preparation, And that's where things would be done, such as developing the conceptual model for what the implementation strategy might be, to identify sets of candidate components, and to conduct pilot tests and identify optimization criteria. And so what we mean by this might be done largely through qualitative research. This is the first time I've mentioned qualitative research in this talk. It's a very important part of implementation science, because what would happen in a MOST design, for example, and even often informally in all of these other designs we've talked about, or many of them, is that qualitative researchers, social scientists, will conduct focus groups and individual interviews of stakeholders at the different levels: clients, providers, health systems leaders, social network members, to find out both what are the facilitators and barriers to them taking advantage of or utilizing and promoting this evidence-based intervention, and then also what their views might be about different components of an intervention strategy or an implementation strategy that would make this evidence-based intervention be adopted, be more acceptable, be used with fidelity, be sustainable, and so forth. And so with that kind of information at the preparation phase, you couldn't really determine definitively what the package would be, but you would get some ideas of what should and shouldn't be in the package. It could be a much larger set than what you ultimately will study. And then at the optimization phase, you would conduct a factorial design that would take as many kind of combinations of these implementation strategies and components as possible, and test them for response for some sort of very short-term implementation outcome, which could be maybe even acceptability, appropriateness, and feasibility. And there are these 5-item scales that have been developed by implementation scientists that can be used in that way. And then based on, say, the responses, you can then pare down what the implementation strategy, what the intervention package should be, to then roll out in a formal either stepped wedge design or cluster randomized trial. So what MOST does is it adds on to these randomized designs that we had talked about earlier, these two phases: the preparation phase, which it can often be largely qualitative, and then the optimization phase, which involves a very short-term pilot, high-level factorial design to weed out the less promising intervention package components. And there's some examples of using the MOST design. And it definitely could be used a lot more often. And hopefully people can see that this is like, sort of a more scientific and rigorous way to use data, not just quantitative data, but also qualitative data, to sort of rigorously design a complex intervention package before it's rolled out. And then there's the question of adaptation versus fidelity. And then that's going to come up for these next two designs. So even after, say using a MOST structure, which would maximize the chances that you would kind of get it right at baseline, I'm sure everybody here who's actually rolled out any kind of complex public health program of any sort knows that the realistic scenario is that this program is going to be adapted as we go along. Providers are going to learn The system is going to learn, clients are going to learn, we're going to learn like what isn't liked, what isn't working, what we can improve, and so forth. And so it's just basically impossible usually for researchers to say, and maybe even unethical, for researchers to say, no, this is a randomized trial and you must stick with this intervention that we set at baseline no matter what. Obviously, that's what we do in a phase 3 individually randomized clinical trial. People either get the new drug or the placebo, and we don't change the new drug after baseline, even if it's people are getting the feeling somehow that it's not doing what it's supposed to do. All we can do is like early stopping for overwhelming evidence of benefit or harm. So this very busy slide is taken from this article down here. And it's a framework for reporting adaptations and modifications to evidence-based interventions. So the reason it's complicated, but that's because what these researchers are trying to do is think of every possible kind of category of adaptation that could take place after an intervention is started, to help people record the adaptations, because those of us who kind of want implementation science to be relevant, one of the 3 R's, realize that we should not only allow adaptations, we should embrace adaptations, because they're only going to likely improve the success of these evidence-based interventions. But the only way to learn in a rigorous way what aspects of adaptation are actually working is to be able to record them. And then once they're recorded, later on in secondary analysis, we can go back and analyze the data, because all of these adaptations are just like exposure variables in a complex epidemiologic study. And using causal inference methods to control for confounding, we can look at which adaptations actually improved outcomes, which made outcomes worse, which didn't do anything. We can evaluate their cost effectiveness and so forth. But if they're not recorded, we're stuck. So that's why I have this very busy slide here. It's a very, very important one in terms of ensuring that implementation science produces relevant results in a rigorous manner. Now we can talk about the learn as you go design. So that's a design that's very dear to my heart, because as you can see here to the left-hand side, I'm one of the people who's developed this design. And it's a new design. We just published it last year. We are in the process of using it in a study going on. Some of you might be part of the HLB Simple Consortium that's supported by the United States National Heart, Lung, and Blood Institute. It's a series of, I think, maybe 6 or more studies taking place in sub-Saharan Africa, where what's being looked at is different ways of integrating hypertension prevention, screening, and treatment into HIV clinics, with the idea that, as we all know, the AIDS epidemic AIDS has become a chronic disease everywhere in the world, and we have aging HIV/AIDS patients, and they're getting chronic diseases just like those of us who are HIV negative. And the concept of integration of care, I think, is a very important one in global health and U.S. domestic health. And this consortium is playing a role in making this happen. So I'm the statistician for one of the projects. It's called POLISA, and it's taking place in 2 districts in Uganda, where we're integrating 2 types of intervention packages into HIV clinics, called Hypertension Basic and Hypertension Plus, to try to increase hypertension screening and treatment and prevention in the clinics there. And we're going to be using this LAGO design. So what is LAGO? Well, first of all, the intervention is a package consisting of multiple components. We've both basically been talking about multiple component interventions throughout this talk. And it can include combinations with treatments, device, care organization, multiple stakeholders. And similar to step wedge design, in a LAGO design, the data are analyzed after each stage. And then what makes it like radically different in a way from other prior study designs is it's actually possible in this design to reconfigure the intervention package and not just do it sort of in a more ad hoc way, as we were talking about with that with the previous with the previous slide on how to adapt interventions. But you do it in a formal way where we have a computer algorithm that will take all the data up to the current stage, analyze it, and then the data itself recommend what's the optimal combination of the intervention for the next stage. And optimality would be determined by both trying to guarantee that we have adequate statistical power to test the overall intervention effect at the end of the study. And then it might be that we're trying to achieve also a certain outcome goal. So like in the POLISA study I was just talking about, we think that about 20% of people in 20% of adults over HIV positive adults in the clinics might have be hypertensive and be in hypertension control. And then we're hoping to improve that to say 40%. So the goal of the study is to get to 40% through the intervention. And you might think that's modest, but another thing that I've seen is sometimes with these kinds of studies, people are overly ambitious and they might say, we want to get like 80 or 90% of hypertension control by the end of the study. But, you know, if we're starting from 5, 10, or 20% to get all the way to like, say, 80%, we're starting to talk about relative risks of 160. Those are like, you know, huge intervention effects that maybe we're being too hard on ourselves when we try to achieve goals like that, even though that's where we might ultimately want to get to. So back to the LAGO design, we can, using the data, we can recommend the optimal intervention package for the next stage. We can also use qualitative data, and we don't have to just use the quantitative data. We can reconfigure the intervention package, then we roll it out again, and then we repeat that up to as many times as was pre-planned. And then we can, at the end of the study, ideally, we would have a final outcome assessment. We test the null hypothesis that the intervention had no effect. We could assess the cost effectiveness of the different intervention components. We have a model that can use that could predict for different intervention component combinations what amount of what level of the outcome we might expect to have, and so forth. So that's the LAGO design. We'll see how it works in POLISA and hopefully some other studies. There's some other projects under consideration for funding that have also proposed to use LAGO. And I'll give an example of LAGO here. This is a post hoc design. So it's an illustrative example that we used in our paper, in this Annals of Statistics paper that was published in 2021. And by the way, not to kind of toot my horn, but just to emphasize the rigor of this design, because it is, you know, very different for people to accept that you can actually change your intervention after you start the study and still have a valid p-value. You know, the mathematics to prove this were quite high level, and the journal where this paper was published, the Annals of Statistics, is kind of considered one of the top and most theoretical journals in statistics. So this design is like really okay. It's okay theoretically, but it does need to kind of be fleshed out in terms of being used and working at the kinks on a practical level. And as we start to use it, I'm sure we'll start to learn a lot of things and be able to further improve it. But anyway, we took the Better Birth study as our example in this Annals of Statistics paper. It was a multi-center study that was conducted in Uttar Pradesh, India, which is a poor state in northern India. And its purpose was to test a multiple component intervention package to improve process and health outcomes for mothers and newborns, that is to lower maternal mortality and neonatal mortality in the state where the rates were unacceptably high. The components involved launching the intervention, how many coaching visits, how many times healthcare providers received coaching visits, how often, the frequency, the duration. There's audit and feedback loops, which is a very popular method in implementation science, where it can be through direct observation or through electronic health records. Providers are audited as to what extent they're actually implementing the intervention, and they're given feedback as to how well they're doing. And then oftentimes there can be group discussions where people talk about, what were the barriers to why they didn't do it more, and how could they do it more often, and so forth. And that's been shown to be a proven way to improve the uptake of a evidence-based intervention program at the provider and system level. And then, of course, stakeholder engagement is increasingly taken to be an important part of successful, sustainable interventions conducted at high fidelity. And so engaging the district and facility leaders was another important part of this package. And there were three stages of the study. In stage one, they piloted this intervention in 2 centers. Then through, non-rigorously, not using LAGO, they then adapted the intervention package and they piloted it in 4 more centers. And then in stage 3, they rolled out a full trial in 30 centers where the intervention was fixed and they couldn't change it anymore. And in stages 1 and 2, they used both quantitative and qualitative data to guide the adaptation. And so this is, again, a very big, ambitious trial. There were 120 sites in 24 districts, and it involved almost 160,000 pregnancies. And the intervention, the primary outcome was an implementation outcome. And it was use of the WHO Safe Childbirth Checklist, which many of you might be familiar with. There are 27 different things that are supposed to be done at different stages when a woman comes in to give birth, with the different stages of pregnancy and right after and so forth. And the WHO recommends that this safe childbirth checklist, which is a means of trying to ensure that these 27 evidence-based components be used, that it should be used at least 90% of the time. So that was the goal of the study. Again, they were, I think in this study, it was at something like 5% where it was happening. So extremely ambitious and probably unrealistic. So, and then we could look at different outcomes. So one outcome is that we looked at, this is again, an illustrative example of the LAGO design, was adherence to oxytocin administration after birth. Or after delivery. And then we could also look at, say, 7-day mortality of the mother and or the child. And then there were also costs, say the costs per coaching session. Okay, so that's an example of the LAGO design. And in fact, just to say that this study was published in the New England Journal of Medicine. And it the design was published here in Implementation Science in 2015, and then the outcome was in the New England Journal of Medicine. And in fact, the trial was not successful in achieving its goals. And probably what happened was, you could say, that's why we said, well, if LAGO could have been used at stage 3, when there were all 30 centers, there could have been more feedback, figuring out what aspects of this is working, what aspects of these components are working and not working, and then maybe some other things need to be brought in. Ike? Oh, somebody else who's maybe unmuted. They failed to increase the use of the safe childbirth checklist to 90%, but they did improve it. But they also, I don't think, failed to see significant differences in, say, health outcomes of mother and or child. So it's an example of how unfortunate it could be to have a very big study like this, with a very complex intervention, following, attempting to implement WHO standards, and then being hard coded in like this. So there's no way to adapt and improve the intervention when it starts to look like it's not achieving its goals. So now I'm going to talk about effectiveness.
Donna?
Yes.
Yeah, it's been a wonderful time. I don't know, how many slides do you have left?
Yeah, I'm not even sure myself. Let me see.
So, because, this is Nigeria and it's about
And it's
9
late, right?
p.m.
Yeah, okay. Oh, I was
So-
almost there, actually.
You're
I'm
almost
almost there.
Okay. Oh,
Good.
good. Okay.
Yes,
Please,
good. So sorry,
go on. Thank
everybody.
It's okay,
I'm
go
very
on.
excited. There's a lot of material to cover, and maybe I should have weeded it down a little bit more, but I really appreciate you all hanging in there with me. I can see we've lost very few
We're
people.
happy with you too, and the lecture is quite illuminating. Thank you.
So I'll just quickly say that because of in implementation science, I've been mostly talking about the interventions in the design point of view, but there's also this hybrid design framework where we can think of combined outcomes or differently emphasizing the health outcome versus the implementation outcome. So there are 3 types, type 1, type 2, type 3. And the goal here in using these hybrid designs is to accelerate transition from effectiveness trials to implementation trials. And this is a very unique design. Here's the reference for it in implementation science. And so the type 1, 2, and 3, I'll show you on the next slide. So in the type 1, the focus is the clinical intervention. So that would be, say, in, let's say, in, and the examples I've given actually, the clinical intervention, none of the examples I've given actually were a type 1 design, because the clinical, let's say with Better Birth, which we were just talking about, the clinical intervention would be, I think actually they were powered for a combined endpoint of maternal and neonatal morbidity and mortality. That would make it a type 1 design. But then they were also measuring the implementation outcome of the extent to which the safe childbirth checklist was used. That's an implementation outcome. That wasn't their primary outcome, so that makes it a hybrid type 1 design. A hybrid type 2 design, which a lot of people are very interested in, would mean that we jointly think we power the study both to ensure that we have the power to detect a meaningful difference in the clinical outcome, but also in the implementation strategy. And they're co-primary endpoints. And then the hybrid type 3 would be focused exclusively on the implementation endpoint. But we're still measuring the health outcome just to get some idea that maybe in this new context or at this greater scale, maybe we might see a difference, good or bad, in the health endpoint. So those hybrid designs, I think, are very useful in implementation science, and I'd encourage you all to use them. So this is my last slide. These are a few textbooks on implementation science that I encourage people to take a look at if you can. Implementation studies require consideration of context, multiple levels, multiple components, timing matters. When you're thinking about conducting an implementation science study, you can identify and rank potential study designs, then decide. And I've gone through a number of the most important ones and discussed some of their pros and cons. We'll consider randomization and real-world rollouts when possible to increase rigor. But also I'm mentioning if randomization is not possible, there are quasi-experimental and observational designs available for which causal inference methods can be applied, and consider some of these innovative approaches if they're relevant to your study. So thank you all very much. I'm sorry for keeping you up so late tonight. It's been a pleasure to talking with you all and sharing this information.
Wow. Wow. Donna, you're fantastic. We are very,
Thank you
very
so much,
grateful.
Dr. Ike. So
Everyone, I mean, we're all still listening to you since you started the lecture. That shows that we really appreciate you. And actually, no other person could have delivered this lecture but you. The expertise cannot be underestimated. We are very, very grateful. And if we look at the charts, oh, it's something that is quite encouraging. I wish I've saved the charts, so I will send this to you. Wonderful time, highly appreciated lecture, stimulating lecture. It's still coming. Wow. Great thanks to the lecturer. So you can imagine. So we're really very, very happy. And really, I'm sure I'm going to be bombarded with requests for you to come again.
Erica Sriracho, who's assisting me with this. Erica, are you still on? Because we should capture the chat. A number of people are asking for the slides, and we can get back to everybody with these slides.
Good.
Yes, yes, Donna. I saved the chats.
Thank you so much, Erica.
Thank you very much, Erica. And so let us have some questions. I'm sure some of us would want to clarify whatever gray areas they have. So I've asked them to send in their questions, but I've not seen one. What we are just seeing is email addresses, send me lectures. So please, our colleagues there, could you please send in your questions? Because she's here now, she can clarify things and also give you some better understanding of the slides that you are requesting for. Please
I know,
do
but
this.
maybe it's so late, EK. Maybe it's too late to actually take questions now. I mean, I'm fine, but I understand it is quite late for people, and I understand if people would like to just say goodbye at this time.
Let me just wait. Maybe can you unmute? Erica, can you unmute? And let's see, anyone raising up his or her hand? Anyone raising up?
I think there are two questions earlier. If you scroll up,
okay,
there were two questions.
Yeah, there is one. There is one here that says, how do we balance between rigor and relevance in implementation science?
Yeah, so it's a great question. Absolutely, yeah, and it's a great question. And my view is there's no right answer to that. It's really you have to say it depends. But in my opinion, I feel that implementation science so far has overemphasized rigor over readiness and relevance, and therefore many of these big studies, including these examples that I've given, have missed the boat in terms of policy. So I might say maybe we need to, if we have to choose, and I've also given examples of studies designs that can maybe be used that could still be rigorous and rapid. That if we have to choose, maybe we need to go over to the others, that the rigorous needs to be, like say, especially randomization, needs to be softened up a little bit so we can contribute to policy decisions.
Okay, thank you very much. There is another question. What is the difference, if any, between implementation science study and implementation research?
Mm-hmm. Yeah, I don't think there is a difference in my opinion. An implementation science study is a type of implementation research. But there's a lot of terminology floating around. So sometimes people say implementation research. Sometimes they say implementation science. In the United States, a lot of people say D&I research, dissemination and implementation research, because they want to emphasize the dissemination piece more. They feel like there's still inadequate uptake and scale up and scale out of a lot of evidence-based interventions for whom acceptable implementation packages have been developed. So these various words are, from my point of view, more or less synonymous.
Oh, thank you very much. Another question is there a difference between clinical and implementation outcomes?
Yes. So that's, I probably should have actually had 1 or 2 slides about that, because that's actually an important concept in implementation science. So I'm sorry I didn't talk more about that, but thank you for the question. So and it's related even to the cascade on my very first slide, where we go from efficacy research has clinical endpoints. That's it. Effectiveness research usually has clinical endpoints. That's it. Then we get to implementation research, we start to have implementation outcomes where we're not actually even looking at the impact of the intervention on the health endpoints. We're looking at the impact of the intervention on how the evidence-based intervention is being implemented, with the idea that the actual public health barrier at this point in time is not like discovering a new intervention. It's rolling out an existing intervention that's useful. And that's where the type 1, 2, and 3 hybrid designs come in, where in a type 3 hybrid design, you would just look at, is the safe childbirth, is the uptake of the safe childbirth checklist, has that increased? We're not looking to see, did fewer mothers die? Did fewer babies die? We know if these 27 things have been done, fewer mothers and fewer babies are going to die. So we just want to get more providers using these 27 things. So that's pure implementation outcome.
Well, thank you very much. I think the last one here, there's one about how do we calculate the sample size for these designs? I wonder how that would be will be addressed. That's the question.
Okay, so that could be another like 1 or 2 hour talk, or even a whole class in itself. But I can say a few basic principles is, if you know how to calculate, say, a study, let's say I'll just say for a cluster randomized trial, compared to an individually randomized trial, you can do the sample size calculation for the individually randomized trial. And there's even, like, in most statistics textbooks, even basic statistics 101 type courses, you'll see the formula for power or sample size for a test, for the difference between 2 sample means or two proportions in 2 groups. You can do that sample size or power calculation and then adjust it by what's called the design factor that takes clustering into account. And the design factor also is a very simple, it's like 1 plus the number of clusters minus 1 times the intraclass correlation coefficient. And you multiply the sample size by that. Or I don't remember the exact details, actually. I'm sorry, I don't want to give a wrong formula and I don't remember it off the top of my head, but you can modify without a computer, just using a hand calculation, you can modify a sample size calculation for an individually randomized trial with this design factor that all it needs to calculate it is the number of clusters and the intraclass correlation coefficient. And then you get your new sample size or your new power for your cluster randomized trial. There are also in R, there are R packages for doing these kinds of calculations for step wedge designs and for cluster randomized trials. In fact, we have an R package that calculates sample size and power for a whole bunch of different variations of step wedge designs with continuous outcomes and binary outcomes and repeated measures and all sorts of things. It's called SWD_PWR, step wedge design power, and it's an R package that's freely available to everybody. So that's just a little bit about how to do this and what's involved.
Yeah, thank you. I think I'll just take 2 more questions. There's one that is quite important, and I think would also help Donna to see how she can help us further, especially those who are interested in implementation research. The comment says, there is generally poor knowledge of implementation research among low to middle income countries researchers, as evidenced especially by the number of publications in Africa. Where can one get specific training opportunities in implementation science research?
Yeah, so that is an extremely important point. And I can tell you a few things about this. The first one is, I'm pretty sure that there's a West African Implementation Science Society. Is there anybody on this call who's a part of this society?
Yeah, Kawisa. There's Kawisa, and there's NISA in Nigeria also. Over.
Yeah, so I don't know, would you like to say something about that and what the society is doing, at least in the West African context, in terms of promoting implementation science, supporting new researchers in implementation science, and so forth?
I know that NISA holds an annual conference on implementation science in Abuja. I've attended that before. I'm very aware that Kawisa is Central and West Africa, and they currently are expanding. I think they have 6 countries in their court, and they're currently expanding into Gambia. I could send to Ike the details of, the 2 organizations who do training. They're focused on training, and they have NIH grant, I think, to support. Yes, they do have 1 or 2 NIH grants to support implementation science research. They just received an R443 to do a training.
Wow,
also.
wonderful.
Yes.
Yeah.
Thank you very much. I believe that is Professor Babalola.
My name is Morenike.
That is
Folayan.
Professor Morenike.
Sorry, Morenike.
She's my friend.
Okay, I know. Okay, please. So, okay, could you just type the names of the societies so that others can click on this? Thank you.
Okay, so that's one thing.
Type it in the chat. Yeah,
so that's one
go
thing.
on there.
And then I know that the World Health Organization has an implementation science academy that's focused on, there's one that's more focused on infectious disease, and then there's one that's focused on chronic disease. But I don't have the links for either of those. I'm not sure if there's anybody on this call who's participated in either one. And I know the chronic disease one, I'm pretty sure is done in the summer, and I don't remember if before COVID, it might have been that people had to apply and go to Geneva, but maybe now it's done by Zoom and it can be more inclusive. I'm not really sure, but I'm wondering if there's anyone on the call who is involved with either of those trainings, that are connected to WHO.
I guess, please let me advise our participants to actually use the Google. You can type this in the Google and get some of the resources. There are some training programs too. I know the NIH also have the implementation science training program. And you can actually apply for it. It's online, and then in December, you join the group. Yeah, that one.
Didn't you do that one?
Yes, I did that. Yeah. I did that.
Maybe you could say a little bit more to people about
conference.
Yeah, maybe you could say a little bit more about what was involved, because that was a pretty in-depth training, I think, that you were able to access.
Yes, it was actually for about 3 months or so, and we had the training online, and we had exercises, assignments, and we had also facilitators or resource persons for the different lectures, and a lot was given on the theories I mean, they really went in depth so that they were well grounded in the theory of implementation science, and then the various examples. And this was capped by a meeting in Washington, and there was a conference, and we also had some sessions, small group sessions, and I mean, just to experience the different kinds of implementation research that has been carried out, and it was quite helpful. So I guess with the emails we have, but like you said, you can just Google and you can actually access all of this. And like Donna said, there is also this WHO implementation science training. That's also free. And so we can, I mean, you can access all of this at some point, but you can get back to me if you need further information on this. And we have also heard about others who can help. So if you get that, the names of the society or organizations, it will also help us to link and network amongst ourselves on this implementation science and implementation research across the continent and even the globe. So a lot of network is there for us. I have two people raising up their hands. I have to allow them before we end this. I have Dr. William and I have Professor Chinedu Babalola. Dr. William, please let it be brief. Thank you. Dr. William?
Better tell Dr. Spiegelman that too.
Pardon me, Donna?
I said you better tell Dr. Spiegelman, let it be brief also. I'm just joking.
Hello?
Okay.
Hello, good evening.
Hello, is that Dr. William? Yeah, thank you.
Yes. Good evening, ma.
Yeah, we're
Good
hearing
evening,
you.
ma.
Yes, we are hearing you.
Good evening.
Yeah.
Hello.
Yeah, the lecture is awesome. I had a lot of new things that were being taught, but my question majorly is concerning the hybrid research that you mentioned. That is it the same thing as mixed method research, and that since HIV is a chronic disease now, would it be better to do the research that you want to do in East Africa, that's in Uganda, also in West Africa, also to see if there are changes in the, though they are both blacks, but the different terrains and all that will also help in the in managing the patient. So those are the issues I have. Sorry. Thank you.
Great. So I'm glad you asked that question. Hybrid designs and mixed methods are not the same thing. So hybrid designs well, let me say mixed methods, which I didn't really talk about. It's another thing I could have actually included in this talk, but mixed methods involve the mixing of qualitative and quantitative research along the entire study process. And there's different types of mixed methods designs, depending on what's considered to be more important, the qualitative or the quantitative. So like you could say the MOST design, which I did talk about as a mixed method design, because phase one of the MOST design is usually at least has a qualitative component. We use qualitative data to kind of narrow down the intervention package components. But then we'd use quantitative data in phase two in MOST to further weed them down to what we're going to use for the intervention we're going to roll out in the full trial. But it's recommended, and even though I have really almost no social science training, I've come to deeply appreciate and value the role of social scientists in implementation science. And I would say that we need qualitative research along with quantitative, along the entire pathway from qualitative and quantitative data about what is and isn't working about the intervention, if it's been in place, or what people think about a new kind of way of adapting the intervention to a new situation. And then you kind of roll out your trial, whatever kind of trial you have. And then while the trial's going on, it's really important to collect qualitative data, because if it doesn't work, we want to know why. So like in the Better Birth study that I mentioned, because it wasn't a mixed method study, we have no idea why there was this failure to take up the safe childbirth checklist. Was it that the turnover of staff was too high, or the supply is not in the facilities? I mean, there's just so many reasons we have no idea. So the qualitative piece while the study is going on is really important. And then you do your quantitative evaluation of your endpoints. And then a lot of people advocate after that further qualitative data collection to find out what people thought of the intervention, what suggestions they have for improvement, what they think the next step might be in terms of scale up or scale out. And so you'd have qualitative and quantitative trading off along the whole continuum. And then also, there's also formal ways of doing mixed methods analysis, where when you evaluate outcomes, you actually integrate the qualitative and quantitative data in some formal ways that I know exist. I haven't actually had the opportunity to do that yet. And so I'm looking forward to learning more about how to do that. So that's very different now, I hope you can see, from the hybrid design, where we have a standard quantitative study design like a CRT or a step wedge design. And the hybrid design is just more about, as the primary outcome, a health outcome and an implementation outcome, or an implementation outcome only.
Okay, thank you, Donna. Professor Babalola, a quick one. Professor Babalola is,
Yeah, thank you. Thank you very
the
much.
Vice Chancellor of one of the universities in Nigeria.
It's all right.
You're welcome, ma.
It's
Thank
all
you.
right. Thank you very much, Professor Donna, Professor Ajayi, and everybody here.
Thank you.
My network, I was on the road, so my network was off and on.
Hmm.
I started listening to implementation science, I think around 2016 at NIH. And what the last speaker spoke about showed up. When they draw the map, it was still new then, you would just see a lot of studies on East Africa, hardly anything in West Africa. You know, I'm just trying to look at the gaps that we need to be filling. I'm challenging those of us present here and our speaker, what really causes that? There's not a balance. You see a lot of studies on that East African coast and very minimal. That's one thing I observed. Secondly, each time I go for these meetings, with all due respect, you're talking about trials, you're talking about these implementations, hospitals, everything. We hardly see those who handle these drugs. We hardly see, I mean, I love multidisciplinary research. That's why I'm here. I believe in it. But we hardly, it could be the fault of those drug handlers, the pharmacists and those that handle drugs, because I was in another group with Harvard on malaria, and it's the same thing. They were even shocked. They say, you are the only pharmacist we've seen in this thing. And you're talking about medicines, and they are not involved. In the hospitals, when I listen to them, they don't even mention them. So we should really be looking at involving everybody in this healthcare sector for the implementation to work. In terms of community pharmacists, they do a lot in Africa. They really need to be brought on board. They do a whole lot. They are the set of people go to meet when they are ill. So we should look at those gaps and fill the skill sets in that area. And then finally is all these other websites and all that. It would be good for those of us here, maybe courtesy of Professor Ajayi, to really do short certification courses on these things, so that we will be well trained. It's obvious that you need a lot of statistics, and some of us may not be good. That's why multidisciplinary approach is very important. Well, thank you very much for everything.
Thank you. I mean,
thank you very
I
much.
think it would be more
think,
interesting and just.
it's time.
Go ahead.
Okay, Donna, I'm with you. Sorry.
Okay, well,
Please go
I
on.
think these comments are probably best discussed by the many participants on this call more than me, because they have to do with, you know, the role of implementation science in West Africa and what are the questions and so the only thing I would just say one small observation that you know, it's an unintended consequence of the fact that, you know, I think to some extent the issue you're bringing up is because HIV rates and was so much lower in West Africa than East Africa. So there was so much funding being poured into East Africa in terms of mitigation of the HIV/AIDS epidemic. And then now, as the epidemic has lessened, it's starting to evolve into some of these other topics. Whereas in West Africa, there just wasn't as much because luckily the AIDS epidemic was just so much less severe.
Yeah, thank you very much for that response. And I think it's a challenge also to researchers in this part of the continent.
I know.
And with this lecture, I think we should start thinking of the various opportunities that are there for us to tap into. So thank you very much, Professor Babalola, for that observation. And I think we should try and bridge the gap and come up with innovative
Professor Babalola, Professor Mandela.
Please, so I think we need to really round up. I want to mention that Donna actually moved from one lecture to ours. So we're really very, very grateful because we know by now you should be resting from the various assignments you had all morning. So to round up, Donna, I've just observed, we are wearing this, our clothes are of the same color.
I know, I noticed it also. It's kind of amazing.
Oh, what a coincidence. I'm so happy.
I know.
And that means I need to come back there soon.
Yeah, that'd be great.
Okay, thank you very much. So we have Dr. Akinyemi, who is going to do the vote of thanks on behalf of the Institute for Advanced Medical Research and Training. Dr. Akinyemi, are you there?
Yes, I am.
Okay, please, the floor is yours now. Thank you.
Right. Thank you very much, Professor Donna Spiegelman, for a very exciting and illuminating lecture on implementation science. In doing this vote of thanks, I'd just like to say that this lecture is coming just at the heels of an African Stroke Leaders Summit that we had just last week. And one of the strong takes of that summit was that we need implementation science to reduce the burden of stroke in Africa. We discovered that in Africa, only 7% of hypertensives are controlled. And that begs the question of the need and necessity of implementation science to, to improve awareness about hypertension and other risk factors, and to improve uptake of antihypertensives, to enhance control of hypertension, and of course, to reduce our body. So it's very, very germane to the field of non-communicable diseases on the continent. And I'm sure you wouldn't mind partnering with us in the years ahead, to undertake implementation science research in reducing the burden of stroke in Africa. So on that note, I'd like to, on behalf of the Director of the Institute for Advanced Medical Research and Training, College of Medicine, University of Idaban, I'd like to say a very big thank you for the time you have invested in sharing with us these deep thoughts from your profound wealth of experience and knowledge in the field of implementation science. The director, the entire staff, and indeed the provost of the College of Medicine and the entire University of the community, and including colleagues who have joined from other institutions in Nigeria and across the continent. We're deeply grateful. We trust and we hope to build on this foundational knowledge you've shared with us to advance the field across the continent. Thank you very much, and God bless.
Thank you, everybody. Nice.
Please unmute and let us all give an applause to Donna.
Thank you so much.
Thank you. It's been a pleasure. Thank you so much.
Thank you so much, Donna.
It's a pleasure.
Bye-bye.
Thank you so
Thank
much.
you. Have a good evening, everybody.
Thank you.
Much, Professor Donna.
Bye. Thank you.
Thank
God
you.
bless you.
Bye-bye. Ciao, ciao.
Thank you, Donna. Thank you,
My
Ife.
pleasure. My
So
pleasure.
much.
Bye.
Yes.